Intracranial lesions. Intracranial lesions are classified into diffuse or focal. Diffuse injuries result from a hypoxic ischemic insult to the brain from prolonged shock or apnea occurring immediately after the trauma. In such cases, CT may initially appear normal or the brain may appear diffusely swollen and normal gray word distinction is absent. So, can you see that? There is no, this is the gray word distinction where you can see some sulci and gyri, right? But all those stuff are absent here. So, this is what we call as a cerebral edema or a tight brain, okay. Don't look at the central ventricles here because these two are different cuts. These two are different cuts. I put this slides just to show you the sulci and gyri here, okay. Significant cerebral edema can cause even compression of the ventricles, okay. You need to look at the symmetry of the ventricles, okay. The ventricle has to be symmetrical. Whenever you are commenting about the ventricular symmetry, make sure the patient's head was at the straight line when they took the CT. Okay, if the patient has moved his head to one side, then automatically the ventricles will look as if they are asymmetrical. Okay, so the face has to be looking central. So this is a very central area, right? See this, the face of the patient is slide forward. Okay, and the ventricles of equal size. So if you are not able to differentiate the sulci and gyri, if you are not able to differentiate the gray and white matter, then there is cerebral edema. Okay, so you cannot comment this as a normal. Another diffuse pattern seen in high velocity impact or deceleration injuries is multiple punctate hemorrhages throughout the cerebral hemispheres. These shearing injuries, often seen in the border between the grey and white matter, is called as a diffuse axonal injury, and it has a very poor outcome. So imagine that you receive a patient after a traumatic brain injury. There is absolutely no other injuries in the body. You do a CT brain. You are happy saying that there is no bleed. Okay, you are happy saying that there is no fractures. You are happy saying that there is no cerebral edema or only minimal cerebral edema. But the fact is, if at all you find small punctate dot-like multiple hemorrhages just at the junction of the grey and white matter, it carries very, very, very poor outcome. That is called as a diffuse axonal injury. Okay. So when the brain material is moving very fast because of acceleration and deceleration in trauma, what happens is this kind of grey matter has a very different speed and this white matter moves in a different speed. So when this grey matter and white matter are moving at two different speeds, they cause rupture. Okay, like this. Okay, so this is the head of the neurons which contributes to the grey matter, and this is the axons which contributes to the white matter. So there will be grey matter, white matter rupture. This is called as diffuse axonal injury. Can you see this? There are some dot-like bleeds. This is a diffuse axonal injury. You are able to see that the brain looks more edematous as well, right? Now coming to the focal brain injuries. Focal lesions include epidural hematoma above the dura. Okay, so there is a scalp and there is a bone, that's a skull, right? So the first layer of meninges is going to be the dura mater. This is a dura mater. Okay, so I'm speaking about here epidural hemorrhage is more likely to be a arterial in origin. So next is, and this actually has two leaves which encloses the venous system, some veins, right? So next is subdural hematoma. So subdural hematoma, there will be some bridging venous system, veins here. So this is a dura. Epidural is artery, subdural is vein. These bridging veins can rupture causing subdural hematoma. And there will be direct contusion over the brain or intracellular hematomas also can be present. So these are the focal brain injuries. Coming to the epidural hematomas, incidence is around 0.5% of patients with brain injuries and 9% of patients with severe TBI. It usually is biconvex and lenticular in shape as they push the adherent dura away from the inner table of the skull. So this blood is actually trying to remove or strip off this particular dura away from the skull. That's the reason it's looking like this. Okay, it's usually they do not cross the suture line. If there is a suture line in the brain, in the cranial vault, this particular EDH will not usually cross this suture line, and they usually never cross the center line as well. So this is the EDH. Okay, this is arterial in origin, so they expand very fast. They cause severe compression over the brain, can cause herniation. This is more dangerous than STH. Okay, most often located in the temporal or temporoparietal regions and often result from tear of middle meningeal artery due to fracture. Okay, these clots are classically arterial in origin. Okay, but they also may result from disruption of major venous sinuses or bleeding from the skull fracture. And the classical presentation is lucid interval. In your MCQ, you will be asked a question that there was a trauma. Initially, the patient had some confusion or low GCS, then the patient was completely normal for some time, After few minutes or hours, again the patient GCS dropped. Okay, this is called as a lucid interval. Okay, so this is more common in EDH.